What Freed is, it's a service model and a care package specifically for young people within the ages of 16 to 25 who have an eating disorders for 3 years or less. So it's a specialized evidence-based intervention that helps services deliver treatment quickly and helps people get access to specific treatment, so to specific eating disorder treatment quickly.
Hi, everyone, and welcome back to the Into Place Therapy podcast. I'm your host, Isabel Ball. Today, I'm joined by Dr. Giulia Di Clemente, a senior counseling psychologist with the South London and Maudsley Eating Disorder Service and the National Co-Lead for Freed. And that's first episode, Rapid Early Intervention for Eating Disorders. It's an early intervention model developed in the UK that's really changing how young people access treatment. So we'll be talking about what Freed is, the impact it's had on early intervention, and what we can take away from it for other systems around the world. And I also want to highlight that, Giulia, you took the time to be here even while on a career break, so I'm especially grateful to you.
My pleasure. Thank you for having me. Really appreciate you taking the time to talk about Freed. I'm always happy to do that.
Of course, yeah. And I mean, for me, like as someone practicing in the United States where access and healthcare barriers are such a big part of our reality and our headlines right now, I find it really encouraging to learn about how other countries are tackling these challenges, and models like Freed was really exciting for me to learn about from the outside. And, of course, like not to idealize them, but, it gives us ideas, right, about what's possible. So thank you also for doing that important work. All right, so let's dive in. And for those who are unfamiliar with it, I'd love if you could just describe, what Freed is and, its core principles and why it matters.
Absolutely. So as you mentioned, Freed stands for First Episode Rapid Early Intervention for Eating Disorders. I often find it's quite a mouthful as well. So we often talk about Freed, and within ourselves, we also refer to it as Freed. I think it's easier, and it's also got a nice sound to it. I think it really represents what it stands for and what it means to live without an eating disorder, which I've always really liked. What Freed is, it's a service model and a care package specifically for young people within the ages of 16 to 25 who have an eating disorders for 3 years or less. So it's a specialized evidence-based intervention that helps services deliver treatment quickly and helps people get access to specific treatment, so to specific eating disorder treatment quickly. One thing I often clarify when I deliver training on Freed is that it isn't an approach. So often it gets confused as being a specific therapy approach. It isn't. It's a service within a service. So it's a way for services to adapt what they already do to make sure that they can see people sooner. And it's also a way of adapting evidence-based treatment. So what's already being offered to meet the specific needs of this particular age range. So the way Freed works and what it focuses on is basically this particular age bracket, so 16 to 25, for different reasons. One, because from research, we know that most people tend to develop eating disorders between adolescence and young adult age. And about 50% of first episodes tend to present within this age bracket. Which is why then Freed started by looking at this specific age range. Of course, we're hoping to sort of expand it in the future and to make sure that early intervention is available to everyone, but we needed to start from somewhere. And what's also being talked about now is the concept of emerging adulthood, which is a way of thinking about this particular period in people's life, because it is very unique in the sense that between the ages of 16 and 25, our brains are still developing, our identities are developing, and there's usually a lot of changes happening within this time. So it's when, we finish high school, we go to university, we might start working, we're moving out of, our parents' houses, or we're just moving into universities accommodation. So there's a lot going on. And at the same time, we're being asked to become more independent and to make decisions on our own, which often we don't have the skills to do. Because if I think about when I turned 18, I definitely didn't feel like an adult. I didn't think I could act like an adult. And so this can also have an impact in terms of help-seeking behavior. So in terms of then people accessing services, which is why Freed is specifically thinking about this age range. And the way we're doing that is by adapting the treatments that are being offered. So the way we've modified them is by thinking specifically about early symptom change. So we encourage change from the very beginning. So from the first appointment we have with the person, to make sure that we can get them going and get started with treatment as soon as possible. We then think about family involvement. So even though, as I said, technically we're adults, most of us, and especially during COVID and after the pandemic, most young people are still living at home. So they're still being supported by their parents, which is why it's really important to then involve other people in treatment so that the person has more support outside of the service. Because of the age, we also think a lot about social media and how it's being used. Obviously, a lot of young people are on social media. There's a lot of information on there. There's a lot that they're looking at. And so thinking about how social media can be used in a helpful way for their recovery is really helpful in treatment. And because of what I was saying earlier about all of the changes that are happening in people's lives, we focus a lot on transition. So we think inside the treatment with the young person about how maybe the eating disorder is impacting these transitions, what they need, what kind of support do they need, what do we need to think about so that treatment is more effective. And the reason why we then Freed has a 3-year cutoff at the moment, again, it's very much at the beginning. We really want to expand it, is that because at the moment, research shows that prognosis may be best within the first 3 years of an illness. So change is easier. The sooner we catch it, the easier it is to make changes. This, of course, doesn't mean that someone with an eating disorder longer than 3 years can't get better. I really, really want to highlight that recovery is always possible. There is always hope. So, anyone that has had it for longer, please seek help. Please, come see us. We really do want to see everyone. We want to help everyone. It's just that as with any habit, anything that we're doing for a long period of time, it becomes harder to change. Not impossible, just harder. And so this is why Freed has these 2 specific points and criteria that it uses to then see people within a service. What's also really interesting and different about Freed is that it has a specific figure, which is the Freed champion. So the Freed champion is usually a clinician that oversees the whole pathway. So they basically follow someone from referral to assessment, treatment, and discharge. And often I think of a Freed champion as a bit like an air traffic controller. So they have like an overview of everything that is happening and trying to manage it all and work with the rest of the service. And it means that Freed is always being held in mind. Basically, there is at least one person in the service that always has Freed in their mind and is trying to sort of make sure that Freed is running smoothly, that there's enough resources, that the service is thinking about it, and that we're doing everything we can to be able to offer it. And one of the tasks of the Freed champion, which I've always really enjoyed when I had that role within the team, is the engagement call. So when we receive a referral, we try and call the person within 48 hours of receiving a referral. And I don't know whether in the US it's different, but in the UK, often when services receive a referral, they then tend to send a letter to the person inviting them in for an assessment. And the letter is often a little bit dry, and I think can make then engagement with the service even harder and make a situation that's already scary even scarier. And the engagement call kind of does the opposite of that. So we actually give the service a voice. There's someone on the other end of the phone that kind of talks to you. And also we try and use that time to sort of highlight how important it is that that person has reached out for help. We really try and sort of, think about proactive engagement and change from really that call, from that moment, by highlighting how great it is that they've had the courage to kind of seek help and to come to us. And then we use that time to also answer any questions that they might have, because it is scary. They don't know what to expect. And I think having someone that can give you those answers can make it a little bit easier. And that's also when we try and involve family members. So when we say to the person, for the assessment, we'd really encourage you to bring someone with you so that you have support throughout the day. You're not on your own. and we can start getting that support and expand, I guess, that network around them from the get-go. And when we talk about family, we really mean anyone that's close to them. We know that obviously, at the moment, a lot of young people travel, so their family might not be the closest person they have there. It might be a flatmate. It might be someone that they really connected with. So for us, that's family. In that moment, that's a person that can support them the most. And so we really focus on that. So this is how sort of Freed does things, I think, a bit differently. And the reason why it was thought of is that I think anyone working in eating disorders, but also in any mental health settings, we know early intervention is important. I think it's pretty obvious. It wasn't, that we were reinventing something that we didn't know. It's just that when we looked at the evidence, obviously eating disorders have the highest mortality rate of any mental health illness. And when we looked at a systematic review of the average duration of the untreated eating disorder, which is basically the time from when an eating disorder starts to the time a person starts receiving evidence-based treatment, people were waiting between 2.5 years to almost 6 years, which is a really long time to be living with an eating disorder. And so at my service, with the help of King's College London in 2014, they started thinking about Freed. And so early intervention and how we could make this easier for people. And what it shows is that it confirmed basically that treating people as early as possible leads to better results around treatment outcomes. And what was also really important is that we noticed that by introducing Freed, we didn't make waiting times longer for other people, which was obviously very important because if we're looking at the duration of an untreated eating disorder, we don't want to make it longer for everyone else because getting help is already hard enough. And so that was also really important for us because it meant that Freed wasn't making things worse for everyone else. It wasn't an either or. It was what can we do at the same time so that we can then expand early intervention to everyone else.
Yeah, I mean, that's just awesome. It just sounds like you all thought about so many details and so thoroughly about that particular age group. And just from my perspective as an American clinician, I mean, we are really lacking in involvement of parents at all age groups or just family, right? Even a chosen family. And someone turns 18 and they're an adult program, and that program isn't at all reflective, right, of that age.
Which actually happens in the UK as well, because I think it's very similar probably to the US in that there's a cutoff. So we have children and adolescent services that go up to the age of 18, and then we have adult services, which are 18 onwards. Some services are all age services, so there's no transition, which is great. And again, some services have a bit of flexibility, but most adult services really struggle to think about family interventions and involving families because I think as clinicians, and I did that before Freed as well, we think, well, adult, they could choose if they want to involve someone. So I wouldn't even think about involving someone else, but actually can be incredibly helpful. And, most of us aren't alone, or kind of we have someone that maybe can be supportive or that at least can be really helpful, I think, to think about who could be supportive, because an eating disorder can make people feel really lonely. And actually even opening up that conversation of, maybe there is someone that you could let in and that could be supportive for you in this really difficult time. I think it makes a huge difference. And, of course, people sometimes still say, no, we can't force them. They're adults. At least knowing that that's an option, I think it's already sort of a really good starting point so that they can think about it if they want to.
Mm-hmm. Yeah. And I think I'm trained as a social worker. And so, thinking of it from this whole systems perspective, I love that sort of, I'm a connector in some roles. The Freed champion just sounds like the connector for them. And then, yeah, of course, that family involvement or friends involvement or whoever that is. And so there's really this systems level, I think, thinking embedded in this, which is really awesome.
Yeah, absolutely. So it's trying to think about it at different kind of points within services so that we could really, I guess, engage people at different points, from before they engage with the services to then within the services and what happens once they're in the system.
And one thing I wanted to clarify, so is this for outpatient level, or is it someone would go directly to residential in some cases, or what is that?
Yes, at the moment, most services in the UK, so those that have adopted Freed,
Okay.
are doing it as an outpatient service, mainly because within inpatient services, people tend to get seen pretty quickly. And it works, at least again in the UK, the pathway can be slightly different. But what has been done for Freed, which again, I've always enjoyed because there is a flexibility, is that if someone comes in the service through the Freed pathway and then we realize that maybe they need more intensive treatment because of the risks or because of the support they need at that point in time, we will then support them obviously with getting that treatment, and then once they come out from the inpatient setting, they will come back to the Freed pathway, so they're still getting that early intervention, those adaptations for that age range, so they're still considered Freed, even if they've had maybe more intensive treatment during that time. And the resources we share with anyone. So often even child and adolescent services or inpatient settings will be using Freed resources with other patients because they're not, they're really helpful for anyone, whether they're Freed or not, and whether it's a first episode or not. So yeah, we often share resources in that way. But Freed mainly runs in outpatient settings, mainly because of the way that the system works and how people come into systems.
Okay. Okay. And then I'm learning still about this, but is there sort of like a self-guided component to it or a handbook or
There
something?
can be. So in terms of treatment being offered, there can be. We do have, for example, self-help sort of materials. We have a therapy that's guided self-help. So where that's part of the treatment that's being offered. What you might be thinking of is we have a lot of booklets, which are resources that we've developed that we share with patients during treatment. So once they're in treatment with us and even after assessment, I tend to share resources that might be helpful for them. So for example, we have a social media booklet. And also video. It's like they can choose then if they prefer, booklet or animation. And I will ask them whether they'd be interested in kind of seeing that resource so that they can start understanding sort of what we might want to focus on in the treatment, but also start thinking about these topics that will then kind of be thinking in more depth in therapy. So yeah, it isn't so much about self-help, more resources that we share with the people we see.
I think that's what I was thinking of. And I mean, it's really awesome too that those have been so rooted in research and tailored to that age group to make them effective. And I like that idea too, right? Thinking of what you were saying, that sort of tension between like being independent and in many ways still not quite yet being a full adult. And so I think those resources in some way allow someone to independently reflect and do their work and then come back and have that guidance.
Absolutely. And even sort of we have a whole booklet on emerging adulthood, which I think is really helpful because again, it kind of highlights that all of us have gone through that phase of life where we're kind of being asked to do more, but we're not quite ready yet. And at the same time, everyone seems to be doing better, which of course I think is being, made a little bit worse by social media because everyone always posts like the positive side of things. And so we're always thinking that everyone else is so much better. Everyone else is doing better. They don't struggle with this. And actually, the booklet kind of shows that that's not the case. That's not what we know. There might be maybe appearing that way, but actually what we know is that all of us have struggled with that. We don't feel ready to be an adult. And so it is a period with a lot of variables, a lot of uncertainty. And so even having, I think, that little bit of reassurance that actually I'm not alone, but they don't yet have to discuss it with anyone that they don't want to. I think it can be really helpful in that way. And I've always really enjoyed all the leaflets and all the resources that Freed has produced over the years and continues to produce. A lot of services continue to produce resources. And I think it's a great way of getting people engaged from the beginning because then they can share them with close others as well, help them, understand a bit more what's happening.
Yeah, I like that idea too. It's not just about I mean, it obviously is centered on the person who's coming into the model, but also it has a stretch beyond that or a reach beyond that. Yeah. So looking at sort of the process of scaling Freed, what have been some of the biggest lessons, would you say?
Yeah, I think there's been quite a few. So, in a sense that we scaled Freed nationally between 2020 and 2023. So, it was right in the middle of the COVID-19 pandemic, which was a really difficult time for services. And what we did was we expanded Freed to about 54 mental health trusts in England. And what that means is that about almost like 30,000 patients have received treatment through Freed because of the scaling. And what we've done is we've completed 2 studies to look at what clinicians thought and, what the scaling up was like, what were the biggest barriers, what were the biggest facilitators. And the biggest facilitators were hope and enthusiasm. So every time I've introduced Freed to clinicians, they were always really excited about it. As I mentioned earlier, I think we can all see the importance of early intervention. We can understand it. It makes a lot of sense. And so regardless of the fact we introduced it during COVID, so a really difficult time, everyone I've always kind of talked to about Freed has always been really hopeful, really enthusiastic about it, and always wanted to sort of give it a go. The biggest barriers were capacity and competing demands. So especially during the time, obviously there were a lot of changes happening. There was a lot that was being done, in services that they needed to adapt to. So that was obviously really difficult. But when Freed was delivered as intended, Freed was seen as working well by both the staff and the patients, which I think is really important. And what these studies also gave us were some further ideas about how Freed can continue working and how it can continue sort of to be delivered as intended. And one of the main things that services always highlighted was funding, the importance of funding, because without funding, obviously, there's fewer resources, the workforce struggles, and so we aren't able to then deliver Freed as we would like to. What they also wanted to think about was a greater variety in terms of treatments being offered, and perhaps thinking about the workforce and how it can be expanded, which is why we then also did a study on peer support workers, which I think they're a great force to be added to, services. And so we've done some research into kind of looking at how they can be included into the Freed pathway and how we can use their knowledge and their experience in a really helpful way. What then clinicians also really liked about Freed and what they highlighted in these 2 studies we conducted is that they really appreciated the focus on kind of outreach work. And from sort of 2020, since I've been sort of working with these services, I've always been very impressed with kind of how creative they would get in terms of reaching out, going into schools, going to universities to make sure that they could then reach as many people as possible. And also they could make sure that they were getting the appropriate referrals. And that's been really inspiring to see and really exciting also to see what other services come up with, especially at a time when maybe funding and capacity was limited. And what was really, really nice to see is that when we've done further kind of research during the pandemic was that despite the pandemic, Freed was replicating sort of our earlier findings from early studies. And in particular, one thing was around the positive clinical outcomes. So about 71% of patients were below the clinical cutoff when we were using the EDQ, which is a questionnaire looking at eating disorder symptoms. So they were below clinical cutoff, which meant they technically didn't meet criteria for an eating disorder diagnosis. And this was compared to 65% in our initial studies. So by rolling out Freed nationally, it seemed we were doing even better than we were when it was, within a few services, which was really great. And yeah, I've always been sort of really amazed by services, kind of their creativity, their willingness to make Freed work, especially during times when, things were really difficult and we were just needing to adapt. So I've always been very, very impressed, and I've learned so much from other services when working with them in terms of what they were doing, how they were reaching out to people, how they were adapting kind of their services to be able to run Freed in the way, that it was intended. So I think, overall, in terms of scaling, what we've learned is that people do want to be able to deliver early intervention. It makes sense. They see it, they want to be able to do it, they can see the difference it makes in people's lives and in services kind of demands, and how it can be really helpful for literally everyone involved. But what they struggle with is often the funding and, what they're being asked to do, because obviously there is a lot of demands. And what we've noticed is that, especially during COVID, sort of referrals almost doubled for most services. So obviously the demand was higher, and we needed to think about that. But that never stopped services from continuing to deliver FREED, which I think is really inspiring.
Yeah, and I think there's so many lessons there for other countries as well, because funding, we were talking about this earlier, is always going to be a challenge for various countries in different ways. But it's exactly that rollout where the creativity is of, okay, with what we have, how are we going to make this work? And that's really promising. And it just seems like the energy is there too within the services.
Absolutely, yeah. FREED has a great network community where we're always kind of sharing resources. And I think it's great because before FREED, I think it all felt a bit disconnected. Most services were doing their own things, which meant that often we were all kind of doing the same thing and creating the same thing over and over, which means that you're kind of not saving up on resources. And actually, by being able to share with other services what you've already created, then you're kind of saving up on time that can then be used for clinical hours, for seeing people. And so I think it's really helpful. It's great to have this community, because we then share, we learn from each other. If someone is a little bit ahead of you in terms of implementing FREED, then they can tell you what they did in a similar situation. And I think that's always been one of the strengths of FREED and its network community. So yeah, I think especially in other countries, I'd say, trying to set up or at least join kind of the current kind of FREED community, because it's really helpful to be able to share resources and to learn from each other, which I think sometimes we struggle with doing.
Mm-hmm. Yeah, absolutely. And in sort of the spirit, right, of this collaboration, how have the multidisciplinary teams, right, whether it's psychiatry or psychology, et cetera, involved in eating disorder treatment adapted to working within the FREED framework?
I think most of the times it's been really positive and fairly easy, because FREED is a service within a service. Often what services needed to do and what teams needed to do was kind of just slightly modify what they were offering to be able to then run FREED as intended. However, what we did notice is that for FREED to run smoothly, everyone needs to be on board. So from the service lead to higher ups, because it means that if everyone is on board with FREED, then there is more support for the service to be able to deliver FREED as intended. So it means, for example, that the champion is given time to be able to do that role, that other clinicians are being given the time to be able to see FREED patients as well as other patients. And they're being supported in running FREED smoothly. So I think that's always been really, really important for us. So whenever we've done training, we've always said, it needs to be the whole team that comes. Even if people might not be involved with FREED afterwards, we still want you to come so that at least you know what it is, you understand it, you can get on board, and you can then support each other in running it smoothly. But overall, I'd say clinicians have always been very, very positive, very enthusiastic. They really like the engagement side of FREED. So especially the engagement call, I think it's fairly new. And even though it can feel at the beginning as if it's extra work, it's actually really, really exciting. It gives you a lot. Like I remember it was one of the areas I like the most about being FREED champion, because it's really nice to be able to talk to people, to kind of have that initial conversation, to offer them a bit of hope, and to really kind of highlight, the importance of the step that they've taken. So I think it's why then a lot of clinicians actually end up really liking it. And it's a 10-minute call. So, we're not talking about a huge amount of time. We're just trying to get in touch with someone. So even though at the beginning it is a little bit of extra work, once you get used to the system, then it becomes a lot easier. We did have some, queries often when introducing FREED, and sometimes we did have doubts, which I think makes sense. one of the main doubts and questions we would always get is, what about other patients? What happens is Freed taking resources away from non-freed patients. And, as I said earlier, it isn't an either or. So Freed, of course, isn't meant to be taking resources away. Actually, the opposite. We're trying to create more resources, more availability and services. And it is really important for us to highlight that actually introducing Freed doesn't make waiting lists longer for other people, because, of course, we would never want that, because we know people are already waiting a long time. So we don't want to make it worse for everyone else. And what's also really helpful about Freed is that it has cost savings associated to it. And so those costs and those savings, well, actually those savings can then be put back into the service, so that actually can then be used for other areas in the service to make sure that it's being, it's working in the way that it needs to, and that it can support as many people as possible. So I think that's what we would say when someone would ask, what about everyone else? And as I said earlier, because of the way research works, and because of, at the beginning, when you start, you've got to start from somewhere. This is why we have this criteria for Freed. But ideally, we'd really like to expand it to everyone, so that regardless of illness duration, regardless of age, they can then access, interventions as quickly as possible. But it needs a little bit more time. But it isn't taken away from other people, which I think is really important, of course, because we don't want to do that. And another kind of maybe thought that some people would have is, yes, early intervention, great, makes sense, but we should really make it earlier. By that stage, it might be too late. And, yes, partly it is true in the sense that we are thinking about intervening much earlier, and there's quite a few projects that have been done, such as the peer support workers project I was mentioning earlier. That means we're getting sort of more workforces so that we can get in touch with people earlier. We can do outreach work. We can go into schools, and we're thinking about doing that. We're also developing Freed M, which is a smartphone-friendly online decision-making tool, which consists of kind of personalized feedback on self-reported eating disorder symptoms and their impact. So it talks about social media use and readiness to change and seek help, so that we can support young people into getting help sooner. So we try and reach out to them before they even get in touch with the service. So before they've even come in contact with services, we're trying to support them into making these changes through an app, which might be more age appropriate and something that young people might be engaging more with. And what we're also doing is we're collaborating with Edify, which is a 4-year program of research that's focused on looking into how we understand and treat eating disorders in young people. And all of the research and material is being co-produced with people with lived experience, so that we can make sure that what we're looking at and what we're producing is actually helpful for the people that we're hoping to help. So we are trying to kind of then make early intervention even earlier. And we're trying to kind of do that by reaching out into communities and reaching out to also GPs and anyone that might be coming in contact with young people. So schools in particular, I think, makes sense. But one step at a time, we're hoping to get there.
Mm-hmm. Yeah, I mean, this is a huge project, and I think what it sounds like you all are doing really effectively is like, okay, bite-sized chunk, what are we seeing, what are we learning, what should we adapt, and then slowly taking on more. Because, correct me if I'm wrong, my understanding is it didn't start with 16, as low as 16?
It did, is just that within our service, because of the split in services in the UK, we see people from 18 to 25 because of the way service works, and most services will be seeing young people from the age of 18 because of that split in provision and what we can do. But ideally, yes, and it started from 16 to 25, and then some services tried to expand it, and then sort of, we're still kind of looking at age ranges and what can be done. But it did start from 16 to 25. It's just that most services in the UK couldn't because of that split and kind of who we're allowed to see.
Okay. And over time, that's something that will be played with or explored. But yes, these things definitely take time. And I mean, to be honest. Hearing all the things you have done in the time that you have is just really impressive. So, and we've been talking about wait times and recovery rates, and you've given us some statistics, but can you tell us some more about what the evidence says about Freed's outcomes?
Yes, so there's always more evidence that needs to be done, and we're always encouraging services to do more research and also in particular to do more independent RCTs so that we can get more information about Freed. But so far, what we know is that Freed participants often wait significantly less time from referral to start of treatment compared to treatment as usual. So, for example, the waiting time from referral to assessment reduced by 32% for Freed patients, and the waiting time from assessment to treatment reduced by 41%. What Freed also showed is that the duration of the untreated eating disorder was significantly lower. So it means that people were going for shorter period of time with an untreated eating disorder, so they were being seen sooner, which is what Freed is meant to be doing. In terms of the treatment uptake, almost like 100% of Freed patients kind of remain in treatment and don't drop out. So it's 97% within Freed compared to 72% of treatment as usual, which is great. And yeah, it's one of those kind of statistics that often kind of catches me off guard, because I think it's really impressive. And I think for people that work with eating disorders, we know that engagement is one of the main difficulties, I think, because of the way eating disorders work. Obviously, they isolate people, which means that they then make it harder for people to get help and to sort of accept that help. So I think I'm always very, very impressed by these statistics, and I'm always very pleased, obviously, with it. What I think is also really helpful is to think about the fact that even though the number of sessions being offered for Freed and treatment as usual are pretty much the same, so between 16 to 20 sessions in outpatient services, what Freed did was reduce the need for intensive treatment. So it reduced it from about 12.4% to about 6.6%, which means that then when someone goes through the Freed pathway, they're less likely to then need more intensive support, which means that they're getting better rather than sort of, deteriorating or needed kind of further support. And what that means is that there's huge cost savings kind of associated with it. So we calculated that Freed kind of helps save around £4,400 per person, which is obviously money that can then be used in other areas of the service. And this includes kind of the cost of the Freed champion, who's, this kind of specific figure within the Freed pathway, which is great. And again, sort of one specific statistics that I often find really inspiring is that for Freed patients, about 60% don't have a diagnosable eating disorder at the end of treatment. And this remained both at 1 year and 2 years kind of follow up, which means that the effects are long lasting. So most people don't come back then to services, don't need further input because we caught it early. And so, they could then go and live their lives without an eating disorder. And when we asked then Freed patients what they thought about Freed, because of course, it's all well and good that we have all of these positive statistics, but if people going through the pathways don't find it helpful, then that would be a whole other story. But when we're interviewed Freed patients, about 95% were really positive about their experience. And what they really highlighted was that the things they found most helpful wasn't just about being seen quickly, but what they really found helpful was the fact that treatment was being adapted to their needs at the time, so that it had that kind of flexibility and it could be personalized to what they needed for that specific sort of time of their life. Which, I always think is really nice, and again kind of shows that it isn't just about kind of getting people in early. It's also about then making sure that the treatment is actually helpful and supportive for them.
Mm-hmm. Yeah, and I mean, as a therapist, I think a lot of clients who end up back in treatment often felt that first time didn't really speak to them or give them the tools that they needed and at that age. And so, I mean, I think that absolutely speaks to that piece around these are tools that make recovery more sustainable for people. And that's critical. Yeah.
Yes, absolutely. One of the areas I have to say where we probably need to do a lot more work is the fact that early recognition and diagnosis is especially delayed in young people from ethnic minorities, those from LGBTQ plus and gender diverse communities, those are higher weight and young males. And so we really need to make sure that then services and interventions are being tailored for this particular groups of people so that they can also then get the support that they need, and they can actually get early intervention as well. So this is probably one area where we're still doing more work, but where it's harder to collect data for us within the Freed network. So we're always encouraging services to think about this individually so that we can then still share the knowledge and what we've learned. But we can't collect data because of privacy guidelines, because it's protected characteristics. And so we're unable to actually then get the specifics from services, but everyone is working to think about this individually. So, for example, in Kent, the Kent, Surrey, Sussex Academic Health Science Network, they produced an inequalities toolkit, which they then shared with the rest of the Freed network so that they could support other services in terms of kind of measuring and understanding inequalities in eating disorder treatment, which is great that this is being thought of and being done.
Mm-hmm. Thank you so much for highlighting that, because that's critical, and it's really promising to hear that that's becoming a focus and a priority as it should be. So
yeah, of course, as we were talking about early intervention, and I think it makes sense that early intervention is actually available to everyone, and so it's really important to think about maybe who's being underserved and underrepresented even in research, which is why we're often thinking about this, and we're trying to think about ways in which we could collect data, and why, for example, Edify is really important, because we're thinking about personalizing treatment so that it is helpful for everyone and not just specific communities and specific groups of people.
Absolutely. Yeah. And I mean, kind of the next question I had was about what you see as the next frontier for early intervention. And it seems like this is, a critical part of it. So what do you see as the next frontier for early intervention, both within the UK, but internationally too?
So I always think whenever we did Freed training with services, we would always end with a picture from the cartoon Pinky and the Brain. And when they're like trying to plot conquering the word. And we've always thought of that for Freed. So we'd really like to conquer the word, in the sense that we really, really want to make early intervention as available as possible to as many people as possible. So Freed is the beginning. We know it's promising. It's a promising evidence-based, approach and model, but it needs further consolidation. It needs further research. And in the meantime, we also need to think about, making early intervention even earlier. So, for example, using, the Freed mobile app, but also kind of thinking about personalizing treatments, and as well as kind of expanding Freed outside of the UK, which is already happening. So even within the UK, for example, Ireland has been introducing Freed, and then internationally, we've got Australia, Canada, and the Netherlands, where they've already introduced Freed. So they've already adapted it to other kind of health kind of networks and other ways of working, so which is great. It means it can work and it can be adapted to other cultures, which I think is really important. What we've been really focusing on in terms of the next steps is we've been working with other sort of charities and other organizations to think about prioritizing early interventions in policies, which is something that was done, for example, for psychosis, and worked really well, because it meant that then even government were supporting early intervention, and we're making sure that then funding is available for services to be able to provide this service and this support. And we're thinking about an early intervention declaration so that we can reestablish, I guess, what we should be doing and what it should be looking like. And in terms of Freed, we've been developing a fidelity tool. The paper should hopefully be coming out soon, which is a way for us to work with services that have already implemented Freed to make sure that it's running as intended and as the evidence kind of shows it's working, and not in name only, because it's also a way of then communicating with, the organizations and people that can provide funding to show them what actually needs to change to be able to deliver Freed appropriately, because I think it's really important to communicate not just within our services, but also outside to understand what's actually needed to be able to offer early intervention. And so we're always thinking about also new interventions, brief interventions, anything that can be helpful for services and can help in terms of demands. But really, I think the next steps would be sort of working with policymakers to make sure that actually early intervention is introduced in policies, so that funding is more widely available. We know that eating disorders are already kind of severely underfunded, has mental health kind of difficulty. And so we really want to make sure that early intervention is being thought of so that it can be expanded to everyone, regardless of age and regardless of eating disorder duration. So I'd say those are the next steps. There's quite a lot to be done, but I always find it very exciting. I think it's there's a lot. It's very creative. I think it really sort of makes us think about what more we could do and really involving sort of people with lived experience so that we can co-create, what we're producing with them to make sure that it's actually working, that actually makes sense for them and for the people that we're wanting to help. So I think that's all really helpful. But yeah, really exciting. I always think it's kind of exciting times because I think there's always more that we can do. But this is a good first step, and yeah, we'd really love to do more.
Mm-hmm. I think it offers a lot of hope, much needed. And I mean, what I've been really impressed with too is it's not just implementing the model, but it's really collecting data and being on top of that, which is what we need to change policy in any country. And so that's really exciting to have that, tangible sort of results to be able to advocate for.
Absolutely. Yeah. Yeah. Because I think anecdotally, again, as I mentioned, we all know early intervention is needed. It makes sense. It isn't, it's a no-brainer. We all know it. But of course, we need to kind of demonstrate why it's so important. And I think data is the best way in which we can do it. Both, qualitative and quantitative data. Of course, we also want to hear from people and, be able to collect their stories. But I think sometimes numbers have a way of speaking to sort of policymakers and to people that have to provide funding, because I think that's what makes sense to them. We were saying earlier that maybe for us being kind of psychology, social workers, math isn't our strong suit. At least for me, it isn't. So for me, qualitative data often kind of speaks a bit louder, but I know that that's not the case for everyone. And that's why it's important to collect both so that we have all sides of the story.
Mm-hmm. Absolutely. Yeah, I think that's critical to center. And I appreciate that the research y'all are doing has expanded to address that and center voices. Yeah, then that's where the wisdom is. So, and I'm curious, and this is a big question. I mean, you mentioned that Freed has been adapted to different cultural contexts. And I'm curious, what advice would you give, right, to a clinician or a service that was hoping to do that in a different healthcare system or context?
Well, I think my main advice would be to do it, to get started. I think that was always what we would say in trainings as well. Services, we'd kind of, be a bit stuck or just get started, because once you get started, then you can think about what's working, what's not working. And it's a lot easier, I think, once you've set it up to understand what you need to be able to make it work. Because otherwise, I think we might have a tendency to kind of sit there and talk and think, but then it becomes harder and harder to actually apply it. And so just getting started, I think, would be the best advice. If anyone, I think, outside of the UK really wants to kind of implement Freed, I'd say get in touch with us. We're always really excited to kind of support people and to think with you about how Freed can be adapted. And, as I said, there's a huge Freed network now where we can share knowledge, we can learn from one another. And especially now that Freed is being set up internationally, we really learn from other services as well. And, we think with them about, which aspects of Freed can be taken over, which aspects might need to be, slightly changed so that they actually make sense for, the context you work in. the people you work with, and the population that you serve. So I would also suggest to kind of join the Freed community page on our Freed website, because there's loads being shared on there, and we're always really keen to sort of speak with anyone who's interested in adapting Freed, because of course, the more services do it, the more people do it, the more kind of people can get access to early intervention, which I think is what we're really looking for. So absolutely do it. I'd say that would be my main advice. To just get started and think about, sort of look at the main aspects of Freed, and then think about, what you're already offering. How similar is it to sort of how Freed runs? Because then that also helps you think about, what might need to be slightly changed. What kind of resources do you need? Especially when working in teams, you might need to think about, what are we missing? What do we have? How can we maybe use what we have to then make sure we can still start with Freed? So, for example, when we were implementing Freed in other services, sometimes they would start with maybe one diagnosis to then expand it to the others. It was a way of kind of learning, again, how the service runs and what needs to be done, what needs to be changed. So there's many ways of starting, but that's why, I kind of said do it, because I think everyone has different needs. And once you start, then you can really understand what you need and what needs to be changed. So yeah, it's very exciting and it's very hopeful. And I can't, I hope I can show people how exciting and how helpful and hopeful it is to have Freed as part of your work. It makes a huge difference. And I think it gives you there's a lot of energy. I think it really kind of gives you that energy that you need to then be able to sort of be more creative in your work, with whether it's with Freed patients, non-Freed patients, with everyone that you're working with. But I think it gives you that little extra sort of boost that often we need when working, in this setting. So.
Yeah, I love that. Yeah, I can feel your energy over here. And I mean, thank you personally too, on a personal level, for being here and talking about this, because I think I know I, as a clinician, can get really discouraged, and my colleagues as well, with our healthcare system in the United States, and we can't get bogged down by all the ways that something can't work and all the ways that it wouldn't be possible. And I love that, just like try it and let it evolve and let it grow. And then that feedback loop of when you see change happening, then you have that energy that inspires you to keep going, and I can hear it in your voice. So it's awesome.
I'm pleased it's coming across, because yes, absolutely. I think it's very common, even when we rolled out Freed nationally within the UK, it was a very difficult time. And I think clinicians, we're also human beings, and sometimes, we don't have enough energy, or we're really struggling, and we're kind of constantly thinking about ways in which services can be improved. And it can be really difficult, especially if you don't get the support you need to be able to implement that. And I think Freed can help a bit in terms of, giving you that creativity, and the network really makes a difference, because you get to connect with other people that have done the same, that have had similar problems. They maybe come up with solutions that work really well for them. And so they kind of, they can give you suggestions. They can tell you what they've done, what kind of data they looked at, which is all really helpful. And it really makes us feel less lonely, I think, very similarly to the people that we see and that we support. I think having this network, this kind of support around us can help us kind of lighten the load a little bit, and kind of share it with other people, so that we're not on our own. And when we work with other people, I think the creativity is just easier and better, because it means that then you get different points of views coming in and different ideas, and that's really helpful. That's always, I think, inspiring and a great support for services.
Mm-hmm. Yeah, and the last thing I'll say too is just, as a clinician working independently, I reached out to you completely out of the blue, and to have you respond immediately, and also, the folks from Freed reach out and be so open to this. I mean, I didn't expect to hear from any of you. And so, again, I loved that there wasn't that sense of gatekeeping, but that energy to move this forward for people outside the UK too.
Yeah, absolutely. We don't want to gatekeep, and even though Freed is trademark, and we're really happy with it, and it does feel sometimes like our baby, but we do want to share it because we know what a difference it can make, and so yeah, absolutely. We're always really excited actually when someone reaches out to us. We're always excited, and we always think about what can we do, who could we put you in touch with, is there anyone sort of in your country that maybe has done it already, what have we learned from them, what can we share. And so yeah, absolutely, I'm really glad actually that you reached out to us. That always makes us really happy when people do that, because of course it means that more people are getting the help they need. So yeah, that's brilliant. That's what we're really hoping to do.
Absolutely. Well, Julia, thank you so much for, again, taking this time to be here and for doing the work that you do. And for everyone listening today, you can find out more about Freed in the episode description. I'm Isabel. Thanks for tuning in, and I'll see you next time.